Morning to you, ladies and gentlemen. This is O.P. Yadav, Editor-in-Chief of Indian Journal of Thoracic and Cardiovascular Surgery and CEO, National Heart Institute in Delhi. And it's my privilege to play host to Dr. Pawan Atluri. Welcome, Pawan.
Thank you.
Pawan is Director of the Heart Transplant and Mechanical Circulatory Support and Robotics Program at the University of Pennsylvania in Philadelphia. And he's here with us on the sidelines of the 64th Annual Conference of Indian Association of Thoracic and Cardiovascular Surgeons. Pawan, you have been on the forefront of dual organ transplant. So my first question to you would be in this regard: what really is the indication for liver transplant in a patient who's undergoing a cardiac transplant?
Yeah, that's a great question. And I think we're developing more and more as we go forward. The majority of the cases are liver transplants secondary to cardiac failure, or correction, liver failure secondary to cardiac failure. And it's really three cohorts of patients that we're seeing. The first of which is those patients with biventricular failure, usually following a dilated or non-ischemic idiopathic myopathy, that have got right ventricular failure, elevated CVP, and hence cardiac cirrhosis. The second group is those patients with genetic abnormalities, namely either sarcoid or amyloidosis, which has been described more so by the Mayo Clinic than any other institution. In our experience, it's been a very small population of patients. And the third group, which is those patients that have gone a Fontan operation for single ventricular physiology at an infancy or at a young age and have now matured and they're in their 30s and 40s. And it's wonderful because that operation really has worked well, but we're starting to see failures from that operation.
Sure, but heartening.
And heartening, yes.
Yeah.
It's nice to see that these patients that used to not survive are now living their third, fourth decade. And we could actually do a heart transplant, as I will present our data tomorrow. If you do a combination heart and liver transplant in these patients, we've seen wonderful survival. And as an aside, as we're doing the evaluation, what we're recognizing is all these patients have some degree of cirrhosis and extensive liver damage. So even those patients that we thought would be good candidates for isolated heart transplant, we're recognizing that they have extensive cirrhosis. And ultimately, our entire cohort of patients, these patients have needed dual organ transplant.
Well, it's amazing how when I did my medicine, the textbook of surgery by Love and Bailey, it mentioned in its footnote, it's better to have a living problem than a dead certainty. Yes. And in the Fontans, those who were having a dead certainty, today they're living problems.
Yeah.
That's heartening. Okay, now, when you do dual transplant, besides the logistics and making them fit for either of these transplants, is there any added advantage in terms of synergism, or one transplant gives a benefit to the other?
Yeah, we're seeing a lot of improvement in terms of rejection rates, and we're seeing that the liver can provide a huge benefit in terms of decreased rates of rejection, and it appears to be immunoprotective. And we're seeing that both in our own series, the Mayo Clinic has published their
only
series.
liver and heart, or even kidneys are involved in kidney transplant?
Yeah, I don't know that the kidney provides the same level, but over the years what we've recognized is the liver is an amazing organ that's got the ability to, over time, isolated liver transplants, they're able to wean these patients off immunosuppression and have them really on no immunosuppression. So I think that's the protection that we're seeing. We have not seen the same, at least in our own experience or that I've seen in the published research, between the kidney and heart.
And the heart.
That being said, from a selection standpoint, there's two strategies if you need to do a kidney and heart transplant. You could either do both organs from the same donor, or you can do it from in a staged approach to the heart and then the kidney, two separate donors. The belief is that doing them from the same donor, at least you've got a decreased rate of allosensitization and you're protected to some degree from an immunologic standpoint, so that you aren't going to have a chimera of the recipient plus two separate donors. Right?
So are the rejection rates lower then?
In the dual organ heart kidney?
Dual organ from the same donor?
Would they say that? Unfortunately, the numbers are too low.
So
it's
we are
all
not
theoretical
protected.
at this point. There's not enough data.
And what about the availability of donor organs when you're doing donor organs?
So that's a big challenge. Um, you know, the data in the United States basically is that we've been capped right around 2,400 heart transplants a year. And this has been the case since the early 1990s, really 1990 onwards, we've been very stable. In the last year, we've seen a little bump as secondary to the opioid epidemic that's going on in the United States. And we've seen about an 800 case increase in terms of heart transplants.
Okay.
Nonetheless, though, we're still talking about roughly 3,000 cases. There's 300,000 patients with heart failure. So it's a very rare commodity. And so you raise a very important question, which is how do you give one patient two vital organs?
Yes.
So the ethics are fairly challenging. And this is why we make sure that we do a very thorough evaluation, not only of the medical necessity, the medical ability for that patient to undergo this huge operation and have a good long-term outcome, but additionally also social factors and other factors.
Now, what technically, when you do these dual organ, what is the sequencing and what are the how does it go about? Which do you do first?
So in our practice, what we've done is we do the heart transplant. Additionally, while we do the heart transplant as we're exposing for the operation, the liver transplant team will come in and perform a small upper midline laparotomy,
Okay.
examine the liver,
Yeah.
and they will confirm whether there's cirrhosis or no cirrhosis. If there is cirrhosis, then we proceed. In a few cases, roughly about 12% of our cases, what we found is that the liver appears fine. And this is purely from the experience of the liver surgeon. And we've proceeded with an isolated heart transplant.
Isn't the technology advanced enough to diagnose these things before, and you
would
still
think.
need an exploratory laparoscopy?
Yeah, you would think so.
Yeah.
But I think part of the issue is how do you sample the liver? How do you assess the liver?
Okay.
And so whereas we may see small pockets of cirrhosis, we find other parts of the liver that are valuable, our liver transplant surgeons.
So do you do biopsy on the table for looking at
Sometimes
it, or
we do.
is it just gross morphology through a laparoscopy?
Both.
Both.
I will tell you the vast majority of times the laparotomy is done, the liver is so grossly cirrhotic that
Okay.
so after that, then we do the heart transplant,
Yeah.
fully reverse, achieve hemostasis, and then the liver transplant team comes in. And we'll even fully decannulate, we'll leave one cannula behind, the superior vena cable cannula, and they will use that for their veno-vena bypass.
Okay. So that has to continue, and that was in fact, you preempt that question, but what is the post-operative management in these cases?
So it's a great question, and it's largely the same management as an isolated heart transplant.
Okay.
And so what we do is we take this patient to the cardiothoracic intensive care unit,
Yeah.
where the cardiac surgical ICU team manages the patient. Along with that, of course, the liver transplant team will be involved as well.
So who owns the patient? Let me
Cardiac
ask you.
surgeons.
Cardiac surgeons. Okay. Okay.
But it's really a dual management,
Yeah,
but
sure,
it stays
sure,
under
sure.
our service.
Yeah.
And honestly, the immunosuppression is the same as a post-heart transplant.
Okay.
The difference being over time, we wean the immunosuppression much quicker because of the liver's involvement. And the patient usually are getting discharged right around the same time frame as the heart. It's pretty remarkable how quickly these patients can recover. As you can imagine, they're very sick. Now you give them not only a functioning heart, but a functioning liver.
So do we have any results now to quote?
Yeah,
What are the total number of cases and what are their survival?
So I'll show you the hard data tomorrow,
Yeah.
but the experience is rather limited.
Yeah.
The largest published experience is 159 patients. And that's looking at the UNOS registry for the United States
Yeah.
dual organ experience. It's about 5 years old now. And it was 159 patients with about an 88% 1-year survival.
88, well, that's pretty
And the
good.
survival curve's pretty flat.
Yeah.
So long-term survival has been excellent in this population. Similar results we've seen from our institution, and really the two big series is the University of Pennsylvania X series and the Mayo Clinic series. We're both right around 35 patients, and they're 37.
So, ladies and gentlemen, we are in for exciting times. If I can crystal gaze the ball, probably time is coming where the whole body is going to be transplanted, with Pawan removing everything excepting the brain, and I believe even the brain transplant has been made, some kind of an attempt just a few days back. But as it stands today, heart and liver seem to have some degree of synergism. The recovery is excellent, and they seem to do pretty well at 88% survival at 1 year in a group which possibly wouldn't have survived more than a few days. Well, Pawan, thanks a lot for sharing your thoughts, and I appreciate your coming here.
It's wonderful to be here.
Thanks a lot.